It's my pleasure today to introduce Dr. Jonklaas, our Grand Round speaker. Really a distinct pleasure for me because I've known Jackie for many years, probably all of her professional career. She's a true product of Georgetown education and training, having done medical school, residency, and fellowship here at Georgetown. She joined the faculty in 1998, seems like just yesterday, but that's actually quite a while ago, and has been one of the most productive members of the endocrine division here since that time, with over 80 peer-reviewed publications and 34 reviews and book chapters. I think the real measure of her stature in the field of thyroid disease is the fact that she has assumed a leadership position in the national and international organization of the American Thyroid Association. She's she's led many task forces for ATA. She is the first author on the ATA guidelines for treatment of hypothyroidism. And probably it's not yet a capstone, but it's probably soon will be. She is now serving as the current Secretary and Chief Operating Officer of the American Thyroid Association. That's second only to the President of the ATA, and we fully expect that in the future she's going to be selected to assume that role as well. So you can be assured that today you are listening to the, if not the world's expert on thyroid disease, she is certainly among the world's international experts on thyroid disease. What she'll be talking about today will be both a review on accepted guidelines for treatment of thyroid disease, but also she'll give you a glimpse into the future for some of the questions that still remain to be answered in this field, perhaps by some of our residents and trainees in the audience during their career. So with that, Jackie, welcome to Medical Grand Round. We look forward to your presentation.
And so I'm going to be talking about treatment of hypothyroidism, the basics and beyond. And so what we're seeing here is three before and after pictures of hypothyroid individuals. So each of them on the left is before treatment of their hypothyroidism, and then each of them on the right is after treatment. And you can see that restoring normal thyroid function certainly has an effect on the facial appearance of each of these individuals. And as we go through the talk today, we'll talk about all the other organ systems that are affected by inadequate levels of thyroid hormone. And here is just some more before and after pictures. Untreated lady with hypothyroidism, here she's treated, and another before and after picture. So let's launch into just a little bit of the basics about the thyroid axis and hypothyroidism. So the thyroid axis is a classic endocrine feedback loop with the thyroid gland depicted here making two thyroid hormones, T4 and T3. And it's a classic endocrine feedback loop in that these hormones feed back on the hypothalamus and pituitary, and it's actually pituitary production of TSH that signals thyroid status and controls the output of the thyroid gland. So the thyroid gland is really a paramount hormone of paramount importance in that it affects all the different organ systems of the body. And I'm just showing a few here: development, growth, metabolism, and cognition. But every single organ system in the body is affected by thyroid hormone. And although the thyroid gland makes two thyroid hormones, T4 and T3, it's actually T3 that is the active hormone. So that's what binds to the thyroid response element in cells and causes all the changes that occur at the cellular level in response to thyroid hormone. And there are Deiodinases in the body that are responsible for converting T4 to T3. So again, just to emphasize, the T4 is a pro-hormone, and it's actually T3 that is the active hormone converted in the body by deiodinases in all the tissues throughout the body to T3. And thyroid hormone either positively regulates or negatively regulates genes. It depends on the organ system involved. But deficiency of thyroid hormone leads to altered transcription of RNA and altered protein synthesis in all the cells of the body. And whether it's increased protein synthesis or decreased, it depends on the particular cell. And here you see T3 being taken into the cell and binding to the thyroid response element, causing production of RNA and protein synthesis, and then all the resultant effects on all the organ systems of the body. So we had shown previously the facial appearance of individuals with hypothyroidism with the sort of puffy eyes and facial swelling. Here we're seeing all the different organ systems and the effect that inadequate thyroid hormone can have on those organ systems. So just to pick a few, we may see bradycardia, we may see an elevated cholesterol, depression, muscle weakness or cramps, a myriad of different signs and symptoms that will ensue if someone does not have enough thyroid hormone in their system. So there are actually two ways you can develop hypothyroidism. So the most common type of hypothyroidism is primary hypothyroidism. And what happens in primary hypothyroidism is something damages the thyroid gland. And this is depicted on the first row here, where thyroid hormone production decreases because of damage to the thyroid gland. The pituitary response is to try and help out by increasing TSH levels. So this is what we call primary hypothyroidism. The thyroid gland itself is not working, and this accounts for the majority of cases of hypothyroidism. Far less common is secondary hypothyroidism. So something's affected the pituitary, and this is depicted in the second row. It's the pituitary that's not making enough TSH. Consequently, there's not enough thyroid hormone, and we call this secondary hypothyroidism. And for the rest of this presentation, I'll be talking about primary hypothyroidism. So how does the body signal hypothyroidism? So here we have a graph with a logarithmic scale here for TSH, and that's the pituitary hormone, and a linear scale for free T4. And basically what happens is, as the free T4 falls, the TSH goes up. And on the other hand, if you were dealing with hypothyroidism, as the thyroid hormone level goes up, the TSH is falling. And so you can assess a patient's thyroid status by getting a paired measurement of TSH and free T4. And so you have this log linear relationship between TSH and free T4, and the TSH is signaling the hypothyroidism as it increases. So how do we treat thyroid hormone? So we treat, how do we treat hypothyroidism? We treat it with thyroid hormone. We use something called levothyroxine, which is synthetic T4. This is active when taken by mouth. This is what T4 looks like. It's got 4 iodines. And the levothyroxine that we give is solely T4. And we rely on the body and the deiodinases in the body to convert this T4 into the active T3. And here is T3, and the only difference is it's missing an iodine here. So the goal of the treatment with thyroid hormone is to lower the TSH back into the normal range and obviously resolve the symptoms that we talked about of hypothyroidism. And again, because the TSH is such a exquisitely sensitive signaling system, we can monitor treatment by following TSH levels. And so what we're seeing here is this is TSH on this axis. The green depicts a normal TSH. And here we have folks who are on an optimum dose of levothyroxine. The TSH is in the normal range. If we were to decrease their thyroid hormone dose by a certain amount, their TSH level would go up. If we were to decrease it further, the TSH would go up further. And then on the other hand, if we increase the dose, the TSH drops down. If we increase it further, the TSH drops down even further. And so again, the TSH can be monitored to make sure that someone is on an adequate dose of thyroid hormone. All right, so let's talk a little bit about how we would care for patients with hypothyroidism. So the topics I'm going to cover are listed here, and let's start with initiation of levothyroxine therapy. So how do we go about starting someone on thyroid hormone when they have been diagnosed with hypothyroidism? And let's use a case to illustrate this. So we have a generally healthy 55-year-old woman presenting with symptoms of hypothyroidism. Biochemical parameters confirm primary hypothyroidism. So here we see her TSH, which is elevated above the normal range. Her free T4 is low. And we're given information about her weight. We're also told she's generally healthy. What's an appropriate starting dose of thyroid hormone for this patient? So there's sort of two issues when you start a patient off on thyroid hormone. One is, do you immediately start a full, what you think will be a full replacement dose, or is there any need to incrementally treat the patient? So treat with a smaller dose and gradually increase to a full replacement dose. So that's one sort of question or issue. The other is, what is the anticipated dose that a patient would require? And there are a few things when we're considering these two aspects of initiating treatment. There's a few things we need to consider, including a patient's age and weight. So let's look at a study that actually addresses the issue of, do you need to titrate a patient's dose up, or can you start with a full replacement dose? So this was actually a randomized study that took patients with hypothyroidism without any cardiac symptoms and randomized the patients either to a full replacement dose right at the start or to a low dose of thyroid hormone that was increased by 25 microgram increments every 4 weeks. And so the two groups of patients within this study were very similar. You can see that they're 47 years old, elevated TSHs of 61 and 48. These were the full dose, these were the low dose. And what we see in terms of what happens to their TSH and free T4, we see here that those who were started on a high dose very quickly, obviously because they had a full dose, normalized their TSH, and you see them with normal TSHs, and the free T4 came up quickly. On the other hand, the folks that were started on the lower dose took them much, much longer to achieve a normal TSH, and their thyroid hormone levels took a while to come up. But the real question that this study was trying to address is, did we provoke any kind of cardiac symptoms such as palpitations, cardiac ischemia, or any other cardiac symptoms? And basically, this study showed that in these individuals, there were no adverse cardiac events with going with a full replacement dose. On the other hand, if you do have someone who is known to have ischemic heart disease, we do recommend that you initiate treatment at a low dose and incrementally increase the treatment. And the saying is start low and go slow. And so in general, this may be an approach to use in the elderly who you suspect may have some cardiac disease. So the other issue, other than do you start with a full dose or do you incrementally increase the dose, the other issue is what is a patient going to require in terms of a thyroid hormone dose? And looking again at this relationship between TSH and free T4 at the time of diagnosis, you can see obviously that TSH levels are higher if you've got a low free T4. So it's not too surprising that you can come up with a number of different formulas that basically calculate a dose based on the TSH. So the higher the TSH, the higher the dose that you would calculate a patient may need. And this actually works pretty well. What you're seeing here is the actual dose of thyroid hormone that a patient ends up requiring versus the predicted dose based on all these formulas that employ TSH in the formula. And you can see that they predict, pretty reasonably. And despite the fact that these types of formulas work pretty well, they're not what we commonly use to judge what dose of thyroid hormone a patient requires. What we actually are more used to using is taking a look at the etiology of the hypothyroidism and estimating a dose based on the patient's weight. And so what we have in this table is 3 etiologies of hypothyroidism. So athyrotic indicates the patient has no thyroid gland. It was surgically removed. And you can see that if you just look at data from a number of different studies, these patients tend to require about 1.9 micrograms per kilogram of body weight in terms of thyroid hormone. And then if we look at 2 other etiologies, autoimmune thyroid disease, which is the commonest cause of hypothyroidism, and hypothyroidism that develops after radioactive iodine treatment for hyperthyroidism. And these 2 categories of individuals may have a little bit of residual thyroid function, and you see that they require a slightly lower dose of about 1.6 micrograms per kilogram. So these are the formulas that we would usually use. And this is just graphically showing what I showed you before, that if someone has absolutely no thyroid tissue, they require a higher dose based on their body weight than do these etiologies where there may be some residual thyroid function. So if we go back to Our Lady, who has a TSH of 35 and weighs 71 kilograms, and here's her information right here. If we do the body weight based calculation, we estimate a dose of about 114 micrograms. If we use one of these formulas, we come up with a slightly higher dose, but these are pretty reasonable estimates of what this, this lady might require to treat her hypothyroidism. So, so to summarize, initiation of thyroid hormone, healthy patients can be started on a full replacement dose. It's safe. It also may be more convenient and cost effective. Dose requirement is affected by body weight. Can also be predicted based on degree of TSH elevation and the etiology of the hypothyroidism. All right, so now let's talk about levothyroxine absorption. And again, we have a patient case here. So a patient who's had well-controlled, stable hypothyroidism. She's had a TSH that's been between 1 and 3, which is well within the normal range. She comes to see you with symptoms of hypothyroidism 2 months after starting a new job. Her TSH is now considerably elevated at 30. What are potential explanations for this? So what we're talking about here is that the timing of levothyroxine and its proximity to foods, supplements, and the effect medications can have on the absorption of thyroid hormone can lead to inadequate treatment of hypothyroidism as manifest by an increased TSH. So in terms of the oral absorption of levothyroxine, under ideal conditions, we get about 80% absorption of an oral dose. But this can be decreased by the timing of levothyroxine. So if it's close to foods or some beverages, the absorption is reduced. So food, dietary fibers, a number of different beverages can decrease absorption. And then we know of a number of different gastrointestinal conditions in which absorption is decreased as well. And so let's talk about the absorption and how it's affected by the timing of levothyroxine. And here we, on the left, we have a study where patients changed the time they took their levothyroxine. So here they're taking it at bedtime, they switched to the morning, and you can see the TSH changes reflecting altered absorption. And if we look at this figure here, maybe if we look at, this is levothyroxine taken with breakfast. And here is serum TSH. And you can see if you take thyroid hormone exactly the same time as breakfast, you can have quite elevated TSH levels and quite variable TSH levels. When the same patients were instead taking their levothyroxine before breakfast, you can see the TSHs are lower. And in other words, the hypothyroidism is better treated than when you take it with food. So this is the decreased absorption that you see with food. If we move on to medications that can affect absorption, there are a whole list of them, and I'm just showing a few of them here. And I'm just going to show you data about calcium carbonate and proton pump inhibitors. But there is a huge, long list of things that can decrease absorption. So if we look at calcium, so here are the free T4 and TSH values when someone is taking their levothyroxine without calcium. Here they're now taking it with calcium, and you can see the TSH level has gone up. Same patients, TSH lower here with no calcium on board, higher with the calcium on board. And what we think actually happens is the calcium actually absorbs the levothyroxine in the acidic environment of the stomach. And here's data on proton pump inhibitors, which probably have an effect on absorption by decreasing the acidity of the stomach. So here we have a baseline TSH when the patients were not taking the proton pump inhibitors, and then an increased TSH when the proton pump inhibitors were being used. So these patients would require an increase in their thyroid hormone dose to lower the TSH back to the normal range. So back to this patient who suddenly has inadequately treated hypothyroidism 2 months after starting a new job. Here we see what her TSH levels were, in preceding years. Now she has a TSH of 30. What might be happening? So she tells you that her new schedule with her new job, she's now taking her levothyroxine with a glass of soy milk. And so this has led to decreased absorption. So again, just stressing that food, beverages, medications, these can all potentially decrease levothyroxine absorption. And so the way to treat this is you can tell her not to drink her soy milk, but if that's part of her routine, it's certainly just as easy to tell her to take her levothyroxine last thing at night. And repeating her TSH after this change, she now has a normal TSH. All right, so what about, we talked about medications affecting absorption of thyroid hormone. What about other effects of medication on levothyroxine? So here we have a 64-year-old, stable hypothyroidism on treatment with thyroid hormone. He's started on sorafenib for renal cell carcinoma and then presents with new onset symptoms of hypothyroidism despite the fact that he's taking his usual dose of thyroid hormone regularly. And along with the symptoms he has, when we do a biochemical assessment, his TSH is considerably elevated at 55. So what's going on here? So what effects can medications have in addition to the altered absorption that we already talked about? They can alter transport of thyroid hormone. They can alter metabolism. And we in fact have some medications that will do all three of these things. So it can be very complicated. And all these effects on metabolism and transport and absorption will generally increase the requirement for thyroid hormone. There are very few things that decrease the requirement. So here is a list of just a couple of the medications that will alter transport and metabolism. And again, there are a long, list of these medications, but we're just going to just show a little data about estrogen altering transport and sertraline altering metabolism. So here we have a classic study in which patients who were about to take estrogen, had thyroid testing before the estrogen, and here you see an ideal TSH of 1.1. After beginning estrogen therapy, the same patients now have a higher TSH of 3.8. This graph is the TSH level over time, and these are the individual patients, and you can see how after starting estrogen therapy right here, their TSH levels tend to increase. And what we're seeing here is that estrogen is increasing thyroid binding globulin so that you have more thyroid hormone in the bound form. The total T4 increases, but the free T4 decreases and the TSH increases, as we see here. And again, this is easily fixed by increasing the thyroid hormone dose. And this is an illustration of an effect of increasing metabolism. This is sertraline. So we have some patients who have TSHs mostly in the 1 range prior to sertraline. They're started on these doses of sertraline and their TSH levels increase. And this is showing you the percentage increase in levothyroxine that is required to lower their TSH levels back to what they were before sertraline was initiated. So how about this patient? So he started on sorafenib. He now has a TSH of 55. So here's his information. His TSHs used to be, in the 2.3 range. And what we know is that when patients take sorafenib, we see a decreased T3 to reverse T3 ratio. And what's actually happening is that these tyrosine kinase inhibitors accelerate thyroid hormone metabolism basically by increasing the conversion of T4 to reverse T3, which is inactive. So thus we're increasing the requirement for thyroid hormone by metabolizing the thyroid hormone more efficiently. And so this patient actually required an increase in his dose from the prior 137 to the 200. And there's no concern with the patient needing a higher dose of thyroid hormone as long as it's making the patient euthyroid. So to summarize the effects of medications, levothyroxine absorption is affected by the timing of the administration with respect to meals and supplements. It's affected by medications. The best choice of timing may vary from patient to patient, and many medications affect the dose required by a patient by affecting metabolism and transport. And the good thing is that we can always check whether a patient is adequately treated by monitoring their TSH, and we can adjust their thyroid hormone dose. All right, so monitoring of thyroid hormone therapy. So here we have a patient. She's coming in for a follow-up. Her main concern is that she can't lose weight despite a healthy diet and regular exercise. She dates the start of her weight gain to when she underwent a thyroidectomy and was initiated on thyroid hormone therapy. You see her weight here, BMI here, physical exam, unremarkable. Her TSH is perfectly normal, 1.1, and her free T4 is also normal. So what do we advise this patient when she states that her hypothyroidism is not adequately treated? So there are obviously a number of parameters that we can monitor when patients are being treated for hypothyroidism, obviously including a patient's symptoms and how they feel. The main parameter that we rely on, as we have discussed, is TSH. A number of other things are affected by thyroid hormone dose, including sex hormone binding globulin, cholesterol, body weight, memory. It's harder to rely on these to titrate a thyroid hormone dose. So let's just show a few studies that illustrate that. But first of all, I just wanted to show that even though we had talked about this nice linear relationship between TSH here on a logarithmic scale and free T4, in fact, this is a sort of an idealized depiction here. And if you actually look at patient data, there's a little more scatter in the relationship. And we also see some differences in males versus females and also different age groups. And so probably this is not so much a linear relationship as a sort of curvilinear relationship, but still the TSH is our best indicator of thyroid status that we have currently available to us. And so we can, titrate a patient's dose, if we want the TSH at the higher end of the range, or if we want it at the lower end of the range, we can adjust the thyroid hormone dose. And we're not, if someone has a free T4 that's right at the lower end of the normal range and the TSH is at the higher end of the normal range, obviously we can, manipulate the dose to try and get things squarely, in the middle of the normal range. So if we try and change TSH within the normal range, it really doesn't seem to have much effect on things like body weight, as was the concern of this patient. So here we have data from a study that kept patients for a year with a TSH of 3, and then kept them for another year with a TSH of 1, so a lower TSH. And they looked at change in BMI, body fat, and cholesterol. And these are all on slightly different scales, but all of these changes are non-significant. So this altered TSH over that 1-year period did not affect BMI, body fat, or cholesterol. We obviously are interested in patient quality of life when they're being treated for hypothyroidism, and we have a number of different questionnaires or instruments that we can use to look at quality of life. These are pretty good for looking at change in quality of life when someone is going from untreated hypothyroidism to treated hypothyroidism, but they're not so good or not as much experience with them for adjusting a dose. And so one of the common questionnaires is something called Thypro. And here we're seeing a number of the sort of signs and symptoms that go into the Thypro scale. And if we just pick tiredness, this dotted line is showing a baseline measurement of tiredness before treating hypothyroidism. And then after the hypothyroidism is treated and the TSH is normalized, the tiredness decreases to right here. Interestingly, the solid line is the general population. And so that you can see, even though you've normalized the TSH, these treated patients may be a little different from a general population. And that's a whole other kind of research issue. And this is another study that manipulated the TSH levels kind of within the normal range. So these are patients who were kept at 8 weeks with these different TSHs, 2.5, 1, and 0.3, so a little below the normal range, slightly overtreated. And there's no change in their well-being or assessment of their mental performance or functioning. So no changes with the alterations in TSH. So what do we say to this patient who has a normal TSH and really thinks that her hypothyroidism is not sufficiently treated? You know, obviously this is very, very complex, and this is true not just for weight, but many of the other signs and symptoms of thyroid hormone deficiency, which are very non-specific. But obviously her thyroid hormone dose, you know, does does affect her weight, but there are many, many other things that could also be causing her weight to not be, you know, ideal. So basically we would not expect that increasing her thyroid hormone dose would help with her weight unless we increased it to actually be over treatment of this patient. So we titrate thyroid hormone doses based on serum TSH. The other things that we know that are affected by thyroid hormone status, such as body weight, sex hormone binding globulin, energy expenditure, they're all too insensitive and non-specific. In the future, we may have a better sort of scale, you know, in terms of assessing patient well-being, but there's no really good scale at the moment. And weight and a lot of other things that are related to hypothyroidism may be affected by, you know, many different things, including thyroid status. All right, so iatrogenic thyroid disease. So again, we're going to illustrate this with a patient. So here's a 40-year-old who underwent a total thyroidectomy, and post-operatively, she's appropriately placed on levothyroxine, but then she's lost to follow-up. And you see her as a new patient. She's 40 years old, and she tells you she's going through early menopause because she has insomnia, sweating, irritability, and amenorrhea. So let's talk about iatrogenic thyroid disease. So this is basically treating patients with too much or too little thyroid hormone. Too much thyroid hormone is typically associated with adverse effects on the skeleton and many different cardiac arrhythmias. Inadequate thyroid hormone is associated with elevated cholesterol and an adverse effect on cardiac function and status, and also is affecting mood and memory and concentration if there's insufficient thyroid hormone available. So I described treating hypothyroidism as being a relatively simple thing. We, you know, give thyroid hormone and we monitor therapy. These are 5 different studies that are looking at patients receiving therapy with levothyroxine and looking at how many of them are euthyroid. And so the red depicts normal TSH, euthyroid status, and you can see that across these studies, it's about 60% of patients that are euthyroid, and surprisingly, about 20% are either hyperthyroid, they have a low TSH, or they're hypothyroid with a high TSH. And if we just look in a little more detail at 2 of these studies, again, these are the euthyroid patients, and if we just break down the patients with iatrogenic hypothyroidism into those that are mildly hypothyroid or overtly hypothyroid, you can see we even have some patients who are being monitored while being treated for hypothyroidism that have overt hypothyroidism. So the bottom line is we don't really do a very good job at adjusting thyroid hormone. So if we go back to this patient, She was placed on 150 micrograms of levothyroxine. She has all these symptoms. Was her replacement dose of thyroid hormone correct? That's not really the question. The question is, why wasn't she monitored? So regardless of the initial dose selection, monitoring of therapy is essential in order to adjust a patient's dose. And here you see her labs. She has a high free T4, a very low TSH. So this is iatrogenic hyperthyroidism, and lowering her dose will allow her to have a normal TSH, and her symptoms resolve with a decrease in her dose. And if you had actually calculated her dose based on her body weight, the requirement would have been, closer to about 90 micrograms. So in summarizing iatrogenic thyroid disease, we assess TSH until the TSH is normal, annual assessments thereafter. However, if someone has substantial weight changes, changes in their medication, changes in their medical condition, you may need to reassess the TSH sooner to see if they need a dose adjustment. All right, so alternatives to levothyroxine therapy. And here we're coming into an area that is very controversial and is also an area of very active research. So I'm going to illustrate this with two patients. So we have a 25-year-old taking levothyroxine. All her biochemistry looks perfectly fine. However, she tells you that her mother is being treated with liothyronine. This is synthetic T3. And we'll talk about that in a minute. And the mother is doing well, and the patient would like the same therapy. So what do we think about this patient's request? And then another patient, an older 62-year-old, comes to see you. She had been taking synthetic thyroid hormone T4, returns to see you after having been prescribed thyroid extract. So this is something prepared from animal thyroid glands, and we'll talk about this in a minute, by another provider. She's just started taking the extract and she feels great. However, the biochemical evaluation, she has a low TSH, a normal free T4, but her T3 is very high. So she actually has iatrogenic hypothyroidism on this extract therapy. So what do we think about, this therapy for this patient? So standard therapy is levothyroxine or T4. We do have other, options, including combinations of T4 and T3. We could theoretically treat patients with T3 alone. That's hard because these synthetic T3s are very short acting, so they have to be given multiple times a day. And we also have a thyroid extract, which has a very high ratio of T3 compared to T4. And this is something that is made from pork thyroid glands. So this is the desiccated thyroid extract that the second patient felt good on. And if you were using a combination of T4 and T3, a physiologic ratio is more like 14:1 or 17:1, as compared with what you get from these extracts, which is more like 4:1. So this is very heavy on the T3. So again, we're just emphasizing that T4 is the active thyroid hormone. It's being converted in the body to T3. And the reason that these patients are interested in T3 is really surrounding an issue about potential inadequate conversion in the body of T4 to T3. So again, the standard therapy with levothyroxine, we give T4, it's converted in the body to T3. Whereas with endogenous thyroid function, the thyroid makes both T4 and T3. Again, T3 is what's affecting all the different organ systems. And it's also T3 that is binding to the thyroid hormone response element. And so there is some data, mostly from animal studies, that that when you give monotherapy with thyroid hormone, it sort of alters the metabolism of these deiodinases so that you don't maintain sufficient conversion to T3, and hence patient interest in T3 containing preparations. So we actually do have a number of research studies that have looked at combination therapy, which means treatment with combined T4 and T3. These studies are very different. They use different dosing regimens. The T3 just given once a day, which doesn't really provide T3 levels throughout the day. They have different duration of treatment. Some are 6 weeks as opposed to a year, different outcome measures. So basically, these studies really make it very hard to come to a conclusion about whether combination therapy is effective. And so the results of these trials, if you look at quality of life or mood, which was studied in 13 of these trials, although we have 4 trials showing superiority either on a number of measures or on just a few measures, the vast majority of studies do not show that there's a benefit. And this is illustrated in this figure where we look at a number of different measures that patients are interested in, fatigue and anxiety. And this side of the figure favors combination therapy, this favors monotherapy. And you can see these all these lines cross unity. So basically there really is no difference between combination therapy and monotherapy. And if we look at neurocognitive functioning, which is something, again, that is of interest to patients and physicians, although we do have a couple of trials that show some benefit, the vast majority of trials show that there really is no benefit. Even when we look at preference, so we have some crossover trials that look at preference, and if you combine these 4 trials, there were 128 patients that preferred combination therapy, but then if you look at this other trial, there's an almost equal number of patients that did not prefer combination therapy. And if you look at the parallel design trials, 130 patients in one study did prefer the combination therapy, but our biggest trial of almost 600 patients, there was no preference. And the second patient that we talked about who had been put on the thyroid hormone extract, we only have one study of thyroid hormone extract or one randomized study. And these patients were either put on levothyroxine or extract and then crossed over to the other therapy. And these investigators looked at a large number of quality of life assessments, and there was no difference whatsoever. There was a modest weight loss, and it really was very modest. So this is the extract and the weight of those patients, and here's the levothyroxine. However, there was a slight patient preference for the extract. So if we come back to our patient who would like to be treated with T3, so what might happen if we do agree that this patient could be treated with T3? So it could be that she'll feel better. And if she does, maybe it's because she did have low T3 levels, or she may be unable to convert T4 to T3, and there are some polymorphisms in the deiodinases that may be associated with this, or it could be a placebo effect, and later she won't feel better. On the other hand, if she doesn't feel better, it could be that we haven't achieved the right TSH. Maybe her symptoms are actually not due to hypothyroidism. And there's also some data that just autoimmunity in general. So patients that have hypothyroidism have other autoimmune diseases, and these may be associated with decreased quality of life. So our other patient, she's just started taking the extract, and here we see that so remember, she's 62 years old. We're over-treating her. She's got an elevated T3 and a low TSH. This again is because the extract has this 4-to-1 ratio. So she feels better, but she's got what we call T3 thyrotoxicosis. and she's at risk for cardiac arrhythmias and decreased bone density. If she initially felt better, but then later did not feel better and wants a higher dose, we think this is due to a sort of positive effect of T3 in the central nervous system that the patient then acclimatizes to and now doesn't feel so good. So sometimes patients who initially feel better do not continue to experience benefit. So what do our guidelines tell us? So the guidelines of the various medical societies, what do they tell us about treating patients? So all these guidelines recommend that levothyroxine or T4 is the treatment of choice. And I'll just highlight the most recent guideline. Levothyroxine should be first choice in replacement therapy for all hypothyroid patients. So there's really no sort of disagreement here. But if you look at these same societies and what they recommend regarding combination therapy, so this would be using T4 and T3, really they're very kind of ambivalent about what should happen. So, might be considered as an experimental approach, ATA, insufficient evidence to support routine use. If you embark upon a trial may be considered. So really kind of no good guidance, for physicians in these older guidelines, and more guidelines are, in progress. And just to show the kind of the quandary for physicians, here, this is a theoretical patient who was presented to physicians in a survey. So this is a 29-year-old, frustrated with weight gain, tired, poor memory, work performance. She's requesting combination therapy with T3. Here are her biochemical parameters. Her TSH is normal. Her free T4 is a little below the normal range. And we do often see patients on T4 monotherapy that have usually TSHs in the low normal range. And so in this survey, these physicians were given a number of options about how they would like to adjust this patient's dose if they did want to adjust. And a couple of the options included use of T3 or liothyronine. And this is what the response to this survey was. And so these were physician members of the American Thyroid Association who were surveyed. And here's our color coding here. And the green represents that these physicians would have added T3 and reduced the patient's levothyroxine dose a little bit, or they would have added T3 to their current dose. And so despite the fact that our guidelines are not giving clear guidance to physicians, physicians are using this therapy, which really shows that we need to have more data about the long-term consequences of combination therapy, which we do not have at the moment. And so this is my final slide, sort of looking to the future. So if someone has a inadequately functioning or absent thyroid gland and synthetic thyroid hormone is not the ideal therapy, might we have other options? And so maybe we will in the future. So you can take pluripotent stem cells and sort of give them all the thyroid specific cellular machinery, and they can actually make these nice little thyroid follicles. And so if you remember back to endocrinology, thyroid follicles are kind of organized in this circular pattern with stored thyroid hormone in the lumen. And here is organization of thyroid follicles made from these stem cells in nude mice who've been injected with these or grafted with these cells. So these are nice thyroid follicles. And this is a stain of thyroglobulin, which is, again, the storage form of thyroid hormone. And you can see that these stem cells are making thyroglobulin. So maybe in the future, we might have this as an option for treating patients. And so we've talked about the very simple adjusting thyroid hormone dose. We've talked about all the nuances of, how do we decide whether a patient is euthyroid and what's the ideal therapy. And so I'm happy to answer any questions.
Wow, Dr. Jonklaas, thank you so much. It was an extraordinary overview of thyroid disease and how best to treat it. We have several questions in the chat. Note that it's 12:58. So let me start with one. This is from Dr. Fisher. And his question is, what are the potential harm in using IV thyroid replacement? And he says that consults seem to be weary of it after 3 or more days of use.
So as long as you're monitoring IV levothyroxine, there's really no harm to it. I think in an inpatient setting, the concern about using IV levothyroxine is really a financial one. So the cost of IV levothyroxine is extremely high compared with the cost of oral levothyroxine. And so I think that really drives the pharmacy, and financial concerns really drives, do you really need IV? But there are certain circumstances in an inpatient setting, where someone is being given tube feeds or something like that, that it's really hard to maintain euthyroidism with oral. And so there are many situations in which IV is appropriate. And in fact, if you don't use IV and you inadequately treat the patient, you may actually prolong the hospitalization by keeping them hypothyroid if their TSH isn't normal.
Got it. And are there any times where you would, and I don't think so, but are there any times where based on the level of the TSH, would you choose IV? Or in general, do you just always try to replace orally?
Yeah, so you would really always try to replace orally. The one situation in which we do think that you need IV is something I didn't talk about, which is myxedema coma, which I'll be talking about at one of the resident noontime lectures. So in myxedema coma, the hypothyroidism has been present for so long that all those binding proteins that carry thyroid hormone are depleted of thyroid hormone. And so if you just give little oral doses, you won't return the patient to euthyroidism. You need a loading dose of IV levothyroxine to reoccupy the binding proteins so you can actually get some free thyroid hormone as well. So IV levothyroxine is the treatment of choice for myxedema, coma, or situations in the hospital that you can't otherwise maintain euthyroidism. But almost all outpatient oral is what you would choose.
And from Dr. Sharma, his question was about when patients come in and they ask for a reverse T3 level. Is that of clinical value? He says some of the naturopath doctors ask the patients to get that checked.
The naturopath was who put that patient on the thyroid extract, the desiccated thyroid extract. So there is mainly a patient community, but also a physician community that is very interested in reverse T3, with the idea that if you're making lots of reverse T3, you're degrading your thyroid hormones, your T4, and not getting enough active thyroid hormone. But there's really no good scientific data that we have that you can use a reverse T3 measurement to adjust thyroid hormone. I have patients who come to me, saying, look, this is my reverse T3, and it doesn't tell me anything about what I should do for that patient. We don't have data about that. So it's an expensive test, and it doesn't really help the physician guide therapy.
And then from Dr. Steen, she asked about, what about a mildly increased TSH but normal free T4? So that was that section you were talking about, adjusting within that normal range.
Yeah, so that all depends on how the patient is doing and the patient age. So if an older patient has, say, a TSH of 6 and a normal free T4, that actually may be within the age-adjusted TSH reference range for that patient, and they may not require adjustment. Mm-hmm. If it's a very mildly elevated TSH, they say 5.5, and the patient feels fine, you don't necessarily have to adjust it. But if the patient doesn't feel well, you should at least give them the benefit, of getting the TSH right in the middle of the normal range. So it's really very, individual dependent. And subclinical hypothyroidism, which is a normal thyroid hormone level but a slightly elevated TSH, is also a whole topic unto itself, and also a very controversial area. You know, how much TSH elevation do you need before you have to treat a patient?
And then I know that we're over the hour. I'll ask just one more question from me. You presented the data that you had collected about the use of thyroid extracts, and I was just curious, is this something that you use in your clinical practice?
Thank you for putting me on the spot, Sean. So I have prescribed extract, but my usual course of action is, or what usually happens, I would have a patient who comes to me on thyroid extract, and I would try and get them off thyroid extract and onto a good synthetic thyroid hormone regimen, just because the T3 ratio is so off and they can end up with cardiac problems. So usually I'll try and take patients off. I think maybe twice in my life, I had a patient who was so miserable, you know, who said, I'm going to go to another patient I'm going to go to another physician and get something else if you don't manage my thyroid hormone extract. So I have prescribed it, but I try not to. And I don't prescribe it I try not to prescribe it excessively.
Excellent. Thank you so much. This is fantastic and great for all of us to learn.
Thank you.
Excellent.
Great. Thank you, everyone.
From the crowd, wow, amazing lecture. Thank you. So
thank
that's
you.
one of the drawbacks of this. Maybe we can all do our clapping reaction. So thank you.
Thank you.